It's ReeferMEDness, the podcast, with Trevor and Kirk.
Kirk, we're back.
Hey, Trevor, how's it going?
Good. So, we're going back in time a little bit to an interview you did up north in Little Grand Rapids. Let's talk a little bit about, before we get into the cannabis part, just to kind of set the stage, tell people a little bit about Suzy Pinnick and what you have to do with her in Little Grand Rapids.
Yeah, certainly. Dr. Suzy Pinnick, this is going back to two conversations that I had with her over January and February. Yeah, Suzy Pinnick is a family doctor with a specialty in remote nursing stations and remote care. She's also got some skills in pain management and also palliative care. Now, I know her through work in the north, and she was gracious enough to talk to us. We were sitting in an office, a nurse in charge office. We're sitting there, we're talking. At one point in the conversation, I think you can hear someone come in. I think one of our colleagues came in. I think she was using the fax in the middle of a medevac or something to that effect. And of course, everything's in the nurse in charge office. So she comes in, and Suzy and I keep talking. And what I'd like to hear, what I would like our listeners to hear is that I caught Dr. Pinnick when she was pretty tired. Now, I think we were probably midweek because she would be traveling the next day to another community, so I caught her the evening before. She would have been putting in about a 16-hour day, reviewing charts and patient assessments, plus being on call all night. So it was very gracious of her to talk to us. And as I'm listening to her and as we've been preparing for this to bring her voice from the shelf, I think this is almost a My Cannabis story. So in a sense, what we've got here, Trevor, is we've got a doctor who has come to use cannabis in palliative care. I'm going to speak a little bit more about how this relates to other stories we've done. But that's what I'd like people to hear. I also have another story for you later in the episode, another My Cannabis story from a nurse that talks to us about her experience with cannabis as well. So essentially we've got two My Cannabis stories in this episode.
No, that's good. I just want to set the stage a little bit because I think it's easy for you and I to forget. Not everybody listening are healthcare professionals, so let's just a couple definitions, because I forget people don't even know some of the what we consider basic words. So Dr. Pinnick started out being a family doctor in rural remote. Just that sounds silly, but let's start with simple things. What's a family doctor?
Well, that's your general practitioner, right? That's back in the day. In my day, the family doctor came and did house calls. So family doctors in small towns, in big cities, family doctors don't often have hospital privileges, right? They work from a clinic.
So this is like the doc that you go see, that you and your family go see in their office.
Yes, this is a family doctor. But Dr. Pinnick's specialty is with remote care. So Dr. Pinnick flies into these communities and helps and works in nursing stations and helps with chronic care programs, helps with immediate acute issues. Nurses work in guidelines when we work up north, and there are things we can do, there are things we can't do, and there's things that we need permission from a physician to do. So Dr. Pinnick is that individual that a nurse would call when we're in the north and we need to do something that nurses can do. We need doctor's permission for her. And if we can't, of course, then we medevac, and the doctor would be involved with getting an accepting hospital to find our patient. Another
word that I think I forget that people don't hear every day. Kirk, what's palliative care?
End of life planning. So as people enter palliative care programs, and that is where you have defined yourself as end of life. You have a disease process, an illness that has put you in a situation where you're planning your death and how that death would be.
And just to be very clear, palliative care is not the same as assisted suicide or medical assistance in death.
No, not at all. No.
This is not quote unquote the people who kill you. This is the people who help you go out gracefully.
Wow, kill you. No,
Well, because there's going to be some people who really didn't see the difference between medical assistance in dying and palliative care.
True.
So I thought I'd better just sort of throw that out there.
True. The palliative care program is where you and your family and your healthcare team come to an understanding that you are dying and you will have an end date. Before some of us, you haven't been hit by a bus and you're not in acute care in an ICU. This is a disease that is slowly killing you. The MAID program is a whole different podcast and a whole different episode. We'll have to get into cannabis use in the MAID program, which is medical aid in assisted death.
No, I know it sounds like I'm being picky, but I think we forget that some of the words we use aren't in common use everywhere else.
Yes.
I have asked enough questions at the beginning. Anything else we need to hear about Dr. Pinnick before we let her talk?
No, let's go into it. I think that's it. I wanted people to understand that you're hearing a My Cannabis story from a physician. She says in the discussion, by no means is she cannabis knowledgeable. She is naive in cannabis and is learning. So in many ways, Trevor, what I'm bringing you is a story of how a doctor is learning to use it. And what's a nuance is that what sparked my conversation with her is that she's had experience using it in pediatric palliative care. And the story ends on that note from the second interview. Now, in the middle, we're going to break in the middle. So
I think they'll recognize your voice in the middle.
Okay. All right. So essentially, Dr. Pinnick, can you please introduce yourself and explain to my listeners what you do with cannabis in palliative care?
So as you said, I'm a physician with the WRHA Palliative Care Program, and I work the adult side of the program, but I also work the pediatric side of the program. The pediatric side of the program is newer for me. I haven't... majority of the time I was just with the adult side, but an opportunity came up and they asked me to kind of help on that side, and so I have. So my experience with cannabis is, I would say, limited. And to be truthful, it's not something that I introduce right off the bat for patients. It's usually patient requested. So from the adult perspective, there's a few that I have prescribed, I should say CBD oil.
And this is in the palliative program?
They are registered on the palliative care program. They are palliative patients. And so in that regard, one particular patient, I remember she had a particular cancer, just to kind of keep things private for them, but wasn't getting her pain management wasn't being managed with our usual opioids, and so her family suggested cannabinoids, and so we tried the cannabis oil, and that seemed to work really well for her. I admit that I was a bit scared because prescribing is so, there's no real cookie cutter way to prescribe, right? Do you get what I mean?
Oh, I know exactly what you mean. Yeah.
That if you start off with, like, say, a blood pressure medication, there's usually a starting dose, and then you move up to a next dose, and you go that way. It's not the same for marijuana or cannabis oil, right? Mm-hmm. And things like that. So you're kind of like, okay, so how do I go about this, right? How do I understand? How do I write out this request for this person? In all honesty, I think that's probably why, I'm assuming, that a lot of physicians don't right away kind of say, okay, let's try this, because there's no real protocol to doing it, right? So I think with this patient, when this request came up, it just had worked out that another oncologist from our team, or another oncologist, he's an oncologist, but he also did some palliative care for our palliative team. We had a morning conference on marijuana, right? And so he gave suggestions on how to start prescribing, cannabis oil and stuff, right? And so that helped a lot. So when I looked at the form, I was like, okay, we'll start off with works at about 3 grams a day, right? And you use it as you see fit, right?
You were explaining to me that you had a situation where pediatric palliative care, that a family came to you, and off camera we were off mic we were talking about some of the dilemmas that you were facing with using that. Could you give us a little bit of a history of the patient and the situation you found yourself in?
So this was this particular patient was only 8 years old, and had a brain tumor. And so he hadn't required much, but then one evening when I was on call, I had a request from the parents. Could they try cannabis oil?
And this was CBD oil again?
CBD oil.
Okay.
And at first I was like, I'm okay with it. So you're going to just order it yourself, right? Because that's what I'm thinking. And they're like, no, could you prescribe it for him? And so I guess what brought it on is they had a friend in the U.S. who, I guess, works with oncologists, pediatric oncologists who prescribe cannabis fairly regularly for their patients. So I said, you know what? I said, it's not that I don't want to, but just let me do a bit of research first, because I said I've never done this for a child, and especially a child this young, right? So when, in my mind, I thought this was simply going to be going and talking to some oncologists or talking to people and seeing if, what do you do? How much do you prescribe? How do you go about this? To discover that no one had ever actually prescribed it. They were mostly okay with it, but no one had actually said, here's a script, get some CBD oil. And so I started to do some literature research again. More of it is bent towards the adult side of things. And so I realized very quickly that this was going to be me figuring this out. And so what I decided first was to talk to the head of my program, right, on the pediatric side. And I said, hey, if I prescribe this, are you guys going to be okay with this, right? Because we are a team, and I want to make sure that we're all on board, we're all okay with this. And he's told me to go forth, basically, because he said, truthfully, Suzy, we have parents who do it anyways.
Right. And we're finding that out too. Yep.
They're doing it anyways, whether we're prescribing it or not. So he said, and he says most of the specialists don't really have a problem with it. It's just that fear of prescribing it. And so I spoke to one of the companies that I had used on the adult side, and I spoke to one of the guys there, and he was helpful. And even for him, it was a little bit trying to figure out, given his age and stuff like that, how much we would do. And so basically what I did was say, okay, I normally start adults off at this dose. I'm going to half this dose, and then I'm just going to go a little bit further. And that's what I did for this patient. And so I think I started off with a range of 0.5 to 1 gram or something like that.
A day?
A day.
Okay. And who administered it? Was it the nurses? Was it the family?
Family.
The family.
Yeah.
So this was a prescribed cannabis, so it would have been on the chart.
Yep.
But the nurses didn't. And why was it? How did that work? How was it with working with the nurses on the floor?
Well, he was at home.
Oh, okay. It was a home program.
It was a home program.
Okay.
But you do bring up a very important point, is that the nurses don't usually give cannabis oil, or, we had one woman who actually just smoked the marijuana. that don't have any involvement with that. We have to know about it, and they have to know about it, but basically it's up to the patient.
So she would go outside, and was this a palliative patient that would go outside to smoke, or would she smoke it in her room?
Her brother found her some kind of piece of equipment that she was able to smoke it in her room.
A vaporizer. They used a vaporizer, so no smoke, no.
Yeah.
Okay, and was that allowed?
At that time it was.
This was palliative?
Yes, she was on the palliative care ward.
Okay.
And so she did it, and I think she would do that about 3 times a day.
Okay, and did you notice a difference in that patient compared to another patient? Was she using less opioids? Did you notice any difference in how her palliative care was?
To be honest, I didn't.
Okay.
You know? And this is why I think, from my perspective, I really leave it up to patients, right? Because I know, like, some of our older patients, at least in my experience, I find that if they've never really used marijuana if they've never used it, they tend to not really like it, don't find it really beneficial. And the flip side of that is when we try something like Nabalon on them, I find that it works a little bit better on them. But flip side of that, if I have somebody who's had exposure to using marijuana and give them Nabalon, it's like spitting in the wind, right?
Yeah.
It's not going to do anything.
Yeah.
And so, I even say that. I said, I don't have a problem with it. If it helps with nausea, or if it's helping with your pain, or if it's helping to relax you,
right,
I'm all for it, right?
So
it works.
So in the last couple of days, us talking and we're working together, is it fair for me to say that you're a little cannabis naive?
Oh, no, it's totally fair.
Okay. So in your practice, you've had a few patients that you've just prescribed it for, a peds patient and an adult, and you've had an experience with one particular patient who's doing it on her own. From what you've observed in these patients, is cannabis something that interests you for the future, or is it only something that patients will bring to you? Is it something that has sparked you in your practice? Is that a fair question to ask?
It's not an easy question.
Thank you.
And I don't know if I have a kind of a straight answer for you. I think I'd be more open to, if we're not coming to any kind of, if we're trying medications and we're getting nowhere, right? And they're still having a lot of issues with, say, nausea or pain, right? I think I'd be more open to trying it or prescribing it for my patients. I'm sorry, I'm going to kind of tell a little bit of a story on the side, but I remember I was working on the ward, and we had this one elderly gentleman with some kind of cancer, and I believe his son was a botanist, and his son said, well, let me make this CBD oil for my dad.
Was it Rick Simpson's oil? Was it something called Rick Simpson's oil? Because this is something that the cannabis culture uses. I'm interrupting. I'm sorry.
No. You're I'm learning from you too, right?
Okay.
It could have been he made it, and we would joke and say he made this with love, right?
Oh yeah.
Because this man needed nothing else. He needed nothing else.
And he was on palliative care. Metastatic disease, severe. Doesn't that trigger something in the back?
Never. And so we thought, maybe there's something different. This one is made with love.
Revelation.
Right?
Revelation. Yeah.
It's different from even when we prescribe it and get it from a company. There was just something about what he had done that kept his dad very comfortable.
I believe, if I'm guessing, it's probably something called a Rick Simpson oil. If you look that up, there's a lot of claims to it that your doctor's mind is probably going to go, but there's a lot of people using it in cancer care. It's Rick Simpson's oil.
Okay.
Yeah. When you had that one patient, see, my inquisitive mind, and only because I'm involved with cannabis the way it is I wonder if you went back to the chart and compared that one patient who was using cannabis on her own and compared her opiate use compared to other patients. And the reason why I say that is that in some of the research that we're doing, we're finding people and physicians prescribing cannabis instead of opioids, and they're dropping the opioids and the cannabis is going up, right? And as I'm sure you might know, that there are no endocannabinoid receptors in the brainstem. No. So you can't overdose on cannabis, right? Whereas you can with it. So I guess that's where my intrigue was. What did you check? But I mean, as a busy physician, you've got your practice to worry about.
Yeah, I admit if it's working, and if she was definitely on opioids. I remember that for sure. And she was on scheduled opioids, and she would use breakthroughs because that came out. But to give you a definitive answer of whether it went down when she used, I can't remember. And to be honest with you, I probably wasn't looking for it.
Sure.
I was more looking at, is her pain controlled? Right. With what she's currently on. Including the smoking the marijuana, right?
So when you're ordering pain relief in a chart, you're probably I'm assuming you're giving the nurses a range, right? It's a range that the nurses can work in, and the nurse decides through that range what to give.
Yeah.
Yeah. So I get that. So once you've done that, you'd walk away and come in, and if the pain's managed, then obviously the order was working.
Exactly.
Yeah. And so in the Winnipeg Palliative Care Program, do you know if cannabis is used by any of the other team members? Is it part of the care, or is it only when patients bring it to them?
So when I think about my colleagues, and again, I'm going to make an assumption, but I believe with most of them. And we're a pretty good team with each other. Like, we get along pretty well. Most of them kind of have an attitude kind of like me. Like, if it works for you and you want to use it, let's go forth, right? And if you want me to prescribe it, I can. I think, I've heard others comment, like, it's like, oh, well, how much do I prescribe? What's the dose? So I know what I'm doing. But generally speaking, it's more like, if it works, then go ahead.
Kirk, you want to do your middle bit?
Yeah, the little middle bit is during the conversation, I was talking to Dr. Pinnick a little bit about how cannabis is used in the palliative care program. Forgetting the nuance of the discussion. The nuance of the discussion is most of her palliative care is done at home. And I didn't get the nuance until we were deep into the conversation, and it makes sense to me. She's a family doc, so she's assisting with palliative care at home. So that was a nuance. But however, my question didn't get answered. So I went to an old friend of ours, the old palliative care nurse, Paul Martin, and he basically explained to me a little bit about how cannabis is administered in palliative care wards. And you're familiar with those, and maybe our listeners aren't, in the sense that palliative care hospitals have developed palliative care programs where there are special rooms set up for people and families so that they can have a comfortable death in a controlled environment, because not all people, not all homes are situated for that. So when it happens in the hospital, what Paul was saying, before legalization, a lot of it was up to families. So as we discussed the nuances in both Dr. Dinnick's episode 70, and other times in other episodes, people bring cannabis or brought cannabis to the palliative care wing, and they administered it themselves. And sometimes what would happen is that, they would give people vaporizers. And of course, the smell of cannabis became an issue. So some people were allowed to go outside and consume their cannabis if they brought it in themselves. That progressed into a situation where, and you will know this as a pharmacist, where doctors write orders on patients' charts. Nurses will transcribe those orders into documents that nurses then use to track the medication. The nurses, the bedside caregivers, will then assist the patient if it's oral, if it's suppository, if it's some nurses may actually roll the joint for the patient if the patient's unable to do so. So there's a lot of bedside care being done in these fields, and the nurses, and I guess it's done, and I'm assuming it's also documented. So there is a process followed, and I guess like all things, it progressed with time. So we can return now to Suzy's voice and hear a little bit about the rest of her story. What I'm hearing from you is that it's so new that you're still learning too, but you're not. You want to ensure your clients get access to it and then allow them to learn and use it as they see.
Yeah.
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 Okay.
You know, so far the only time I've ever had to pull back and say to someone, you know, we got to pull back, and that was an older man, and he was quite delirious, and there were some other meds that I pulled back as well, but it was like a step-by-step process. It wasn't like I just did everything at once. Okay. But it was like, okay, let's pull this back and see if that clears up. Let's pull this back and see if that clears. Okay, let's pull this back.
Right.
And certainly when we did, he cleared up somewhat. So that's the only time I've ever kind of said, let's stop that. But generally speaking...
Okay. Mm-hmm. So if there is one thing you would like to share with our audience about using cannabis in palliative care, pediatric palliative care, what is it the one thing? What is it you've learned? What is your soundbite, I guess?
That's not an easy question, because I'm still learning. I think what I'm learning is that with cannabis is that allowing the parents to treat their child's symptom or work with their child using cannabis, it gives them a certain level of autonomy, and I don't know what the right word is, but kind of that parent control of kind of choosing what they feel is best for their child. Right? Mm-hmm. I may not know what all these cancer meds are doing, and we've tried this and we tried that, but let me at least try this too. Okay. And giving them that ability to do that, I have no problem with. And if it relieves the symptoms of their child's symptoms,
why not?
Why not?
Yeah. Why not?
Like, why would you have a problem with that?
It must be emotionally challenging to work in palliative care, but pediatric palliative care must be just turned to 11. It must be that much more intense, because children aren't supposed to die before their parents. Exactly.
And it is hard.
Yeah.
It is hard. I was just on last week, and it was a busy week, and so it's just seeing all the different reactions and how people have to adjust with the fact that their child is sick.
Yeah.
Right? Whether it's prenatally or just shortly after birth. I think I feel really bad for the teenagers because there is an acknowledgement. They know what death is.
Yeah.
Right? They understand the finality of it. And so... When I see certain kind of behaviors and I try to give them an opportunity to voice it loud. Of course, there's social workers who do a much better job than me, but I actually try to bring it up sometimes. I'm like, "Are you scared?"
Yeah.
And they'll say yes or no.
Yeah.
And so it allows them to speak. You know, I am awake at night thinking about this.
Oftentimes, in my experience, and it's not great at all, but oftentimes they're more worried about their parents than they are themselves.
Yes, they are.
Yeah.
Huge.
Yeah.
Huge.
Yeah, they have that insight.
Yep. I've heard that before.
Mm-hmm.
I don't want my parents to be sad.
Mm-hmm.
And I know they'll be sad.
What are your takeaways, Trevor?
Well, let's start with non-cannabis stuff. Palliative care in kids. Like, I have some experience with palliative care in the community. So, people are quote unquote go home to die. We have people, they have palliative, the way their medication gets covered changes. Often we're asked to compound unusual things. Maybe they can't take anything by mouth anymore, and we still have to get their anti-nauseants into them. So I have experience talking to and about and with people going through palliative care at home. Obviously, I knew it was out there, but I never really gave much thought to palliative care in kids, and that's gotta be hard. Like especially, she especially sort of tugged at my heartstrings a little bit there when she talked about teenagers, because many, many, many moons ago, I had a friend in age 15 or so who died of cancer. So, plucked a lot of heartstrings there. So how about just start with just kudos to people who can do this for a living, because I don't think I could do it.
End of life nursing is a specialty. It's one thing about the medical field. We have such opportunities to specialize in different areas, and we all have our skill sets. And I've always appreciated the elder care people, the geriatric care, and those people that do long-term care and palliative care. These are some of the heaviest nursing bedside care positions, and kudos. Yeah, I agreed.
But yeah, now, and I don't mean this in a negative way at all, but Dr. Pinnick is kind of flying by the seat of her pants a little bit on cannabis and palliative. Now, again, this is not, maybe be shocking a little bit to non-healthcare professionals, but you've got to deliver that first baby. I'm never going to deliver a first baby, but if you're a doc, at some point you've got to deliver the first baby. You've got to do the first surgery. You've got to deal with your first your first cannabis patient, and the first time it might seem like you don't know what you're doing, because you don't know what you're doing. But I think it's still important that patients are asking for it, and
yes,
she's trying and getting better.
Yes, but it's interesting. It's I wanted to. We've had this story on the shelf for a few months, and I wanted to bring her story after we did Dr. Paul Dinnick. And interesting enough, going back to episode 71, Paul Dinnick was a name that we had known for a while. You had known about him for 20 years. I'd heard about him, but never thought about an interview. It took Suzy to find the interview for us, and I think when we add these two episodes together, you see how a doctor like Dr. Pinnick would use a mentor like Dr. Dinnick to learn her craft. And Dr. Pinnick has some serious skills. I mean, she's a pain management specialist. She's a rural family doc, which means that she sees more in a day than some specialists see, from all ranges of the medical field. But she's quite prepared to say to us, don't know a lot about cannabis. But here's my story. So I appreciated that side of it.
Yeah, I love the interview. Thank you, Dr. Pinnick. I really appreciate the time and your honesty, and the beginning of what we hope is a long career using cannabis to help people feel better.
Yes, I'm hoping to stay in contact with Suzy. We've got some plans to do some programming in the future together. We'll see if it comes up. I have a second My Cannabis story, a little shorter. This one follows our 1 to 2 minute thing. This is a nurse that I was working with up north. Of course, it's all things cannabis when you're with Kirk, right? I'm always finding a reason to bring cannabis into a discussion. Well, Maureen told me a story about how she had an allergic reaction to it. So let's hear her story.
Let's hear Maureen.
My name is Maureen. I am a nurse. I've been nursing for 43 years. I feel strongly that cannabis is something that is very good for medical issues and stuff, but unfortunately I cannot be anywhere near it, as I am very highly allergic to it. My sister and I went to a concert, and there was no smoking of cannabis in the concert. After we left, there was several groups that weren't even close to us smoking, and you could smell it very much. And by the time I got to the car, my hands and my face were very swollen. So a lot of people don't believe that you can be allergic to stuff, but you can be allergic to anything. People are allergic to the sun. They're allergic to almost anything you can be allergic to. So, but I do feel that it can be very beneficial.
But not for you.
But not for me.
So now, what's interesting about this story is that as I sort of turned the voice recorder off, she looked at me and goes, "Oh, but the times I took the gummies, it was fine." And I went, "Whoa, what?" I said, "What are you you mention that in the narrative? We just did. She goes, oh, well, I didn't think about it until now. So it's interesting. I think what happened is that she had definitely a respiratory effect, a respiratory something, maybe a terpene, maybe a cannabinoid in the off smoke. What do you call it?
Secondhand smoke.
What do you call it? Secondhand smoke. Secondhand. So there's obviously something that triggered the respiratory effect that she had, but yet she can pop gummies and it's not there. So curious.
Well, it is, and again, really appreciate she shared the story, but it just makes my mind spin a little bit. You know, I go all the way back to Dr. Danick and him talking about, you know, obviously we're very canna positive here, but just remember that it is still a medicine. It's not perfect for everybody, for every circumstance. And even Dr. Pinnick in this episode talking about, you know, she had one older guy where it was not going well and, you know, had to back off the dosage and then it got better. But it's just one of these, as canna positive we are, it's good to remember it's not all things for all people all the time.
No,
and
true.
You know, there are potential problems.
Very true. No, I agree. I like hearing these stories, and I'd like to encourage other listeners to send us their cannabis stories, because the stories are what brings education to us. I mean, most of the physicians and researchers we've talked to, they all speak about how their patients bring them the stories, brought them the first nugget of information. So we are always encouraging people to speak to your doctor. I've got a future story coming that I'm working on from another Winnipeg story, another listener story, and it's going to be about someone with long COVID and how she's using cannabis. So that's coming up in a couple episodes. But again, we're learning how people use cannabis in their world, right? And how
and maybe this is as good a place as any for an ad break. We haven't had a 1 to 2 minute My Cannabis story in a while, and we miss them. People love hearing them. And like we just heard, it doesn't have to be about how cannabis is wonderful. We're more than happy to take the I hate cannabis because. We want to keep the conversation going about cannabis. Everybody out there, I guarantee everyone who's listening, and most of the people just out there have some experience, good or bad, with cannabis, and we want to hear about it. So easiest thing to do, record 1 to 2 minutes, say, and we can keep it perfectly anonymous if you want. Record 1 to 2 minutes on the voice memo thing on your phone. Email it to us. All the info's on our website, and we'd be more than happy to put it up. And like I said, we can keep it completely anonymous if you want. But yeah, I think the more people who tell their stories, the more education goes out there.
Exactly. And I guess that segues right into, we are ReeferMEDness, the podcast. I'm Kirk. I'm the nurse.
Again, end of the episode. I'm Trevor Schufeld. I'm the pharmacist.
So thank you for listening.
All right, guys, that was great. It's Renee back here in the studio. And ReeferMEDness, the podcast, would like to recognize that the recording of Dr. Pinnick's interview occurred on the traditional territory of Little Grand Rapids, which is part of the modern-day Treaty 5. As well, we'd like to note that ReeferMEDness, the podcast, is recorded within unceded territory of Treaty 2 of the Anishinaabe. So now we move on.